all doing good. Guys, once again, welcome back to the wonderful OMR series, where this could give you properly an idea about how to run in the OSCEs. So today I have Priya with me. Thank you, Priya, for joining.
Thank you.
Thank you. Today we both will be doing a one structured discussion on a general gynec module. Just to start with the quote, so the best preparation always comes from today. So that is what we are trying to help you guys. So how this would go is, I'll show you candidate instructions and then we would start off. I'm the candidate and Priya is the examiner. So as she asks the questions, I'm going to answer her. And then towards the end of it, Priya will give feedback. And also I'm going to show you probably the best answers, what could be the best in these scenarios. Okay. Yes, Priya. Let's start. I'm keeping the timer as well. Okay. Yeah, let's start. Hello, I am Sowmya, one of the candidates for the exam. I have gone through the scenario and I'm happy to start the discussion.
Yes. So how would you define primary amenorrhea, and also at what age you would like to investigate?
Okay, primary amenorrhea is an absence of menstruation in a 14-year-old girl. If a 14-year-old girl without secondary sexual characteristics or a 16-year-old girl with secondary sexual characteristics, we need to evaluate her further.
So what additional information from this girl you want to know?
Okay, so basically, because I need to come to a differential diagnosis, so I would want to ask a couple of things about the history, which I would move from head to toe, as well as a few examination points. Head to toe, starting from the hypothalamus, I would want to know her lifestyle and the stress level factors, whether she is a pro-fit, whether she is a fitness pro where she has lost a lot of weight. And also, I would want to know if there is any loss of smell because of anosmia and if there is any growth delay. And coming to the pituitary level, because micro and macroadenomas can have pressure changes like headache and blurring of vision. So, and also galactorias in case of prolactinoma, as well as, once again, if there is any familial growth delay and also head trauma or any radiotherapy or chemotherapy or surgeries of that sort. Thyroid, specifically hypothyroidism changes like increase in the weight and the skin changes and all that. Coming to the breast, once again, the breast is still like the galactorias are asymmetry and skin changes which can be evident in the pregnancies. When we move down to the reproductive organs, uterus, if there is a cyclical abdominal pain, which could indicate of cryptomenorrhea or nausea or vomiting indicating of physiological pregnancy, and any surgeries are like especially cancer radiotherapy things to be ruled out. And in ovary, especially chances of virilization, deepening the hoarseness of the voice because of the tumors, or PCOS, excessive weight loss, all those things I need to be careful. And once again, radiotherapy things I need to be very careful about. Also, family history of such things happening in family, any genetic disorders are the familial delay. Examination specifically, I would want to see her height and weight ratio and a tanner staging from breast and pubic and axillary hair. Abdomen, any mass because of the pregnancy or any tumors. And also with the consent, of course, in presence of chaperone, I would be wanting to do that. And also visualizing the external genitalia as well, like clitoromegaly or anything. If it is there, I would like to have a look.
Okay. So what are the investigations that you want to send for this patient?
Okay, so looking into the history and the examination findings, everything looks absolutely fine. Nothing specific in history nor in the examination findings. So I would first and foremost, I would want to do a pregnancy test to rule out the pregnancy. Then the hormonal test like FSH, LH and the TSH, I would want to do. AMH, I'm not preferring at this point of time. And I would want to do a bedside ultrasound. If the uterus is absent, I would go for karyotyping. And if at all, if I'm thinking of Mullerian anomalies, then comes the next like MRI and the pelvic MRI and the renal anomalies for the renal scan I need to be doing.
So these are her investigations. So after going through these investigations, what is the diagnosis she is having and how would you like to manage her?
Okay, looking into the investigation, first of all, the hormonal profile looks absolutely fine. And when I come to the karyotyping, I can see it is both are XX, so it is 46XX. But when I see the uterus, the ultrasound report, uterus is absent or rudimentary. So we are dealing with MRKH, Mullerian anomaly. Sowmya NS Kuster-Hoster syndrome. So definitely this is a diagnosis which could be which could cause a lot of trauma to the patient and to the family. So first and foremost, I would want to involve a multidisciplinary team care, my consultant, especially the adolescent gynecologist, and also the psychological counselor who should be part of this. And there are multiple things which we need to describe to her. First thing is revealing the diagnosis in such a way that she understands. And the second thing is, because in them, the vagina is either absent or rudimentary, creating the neovagina is the prime importance looking into her age. So for the conservative measures or the medical measures like the use of dilators, so probably we need to get into the psychosexual counselor and physiotherapist there. When it comes to the surgical management, there are a lot of procedure like Vijay procedure where we put a traction bead to pull and create a neovagina, or a Dadov's procedure where we use a peritoneum on the mold to create a neovagina, or sigmoid vulvoplasty. Of course, we would be needing the help of the surgical team here. When you come to the fertility thing as such, of course, surrogacy is always an option, adoption is always an option. And also uterine transplantation is something which is a brand new one, which could help, which could help the future woman in perspective. However, we need to be, even the genetic component is very, very, very rare. Probably we need to think of, if at all, if she wants to have from her ovaries, which is very difficult to pick up the eggs as well, but we need to have a genetic counselor in place as well, because this diagnosis not only affects her physically, but also psychologically. So the whole factors should be kept in mind and speak to her as well. Okay, I think we finished quite early. Okay, yes, please, your feedback.
Yeah, so it was well done and well done in time, and also covered almost all the points. So the definition was correct. So without secondary sexual characteristics, if she is 14 years, and with if she is 16 years, so the definition was correct. And additional information, I like the way that you went through from the cranial to the caudal, like hypothalamus, starting from that, what can be the factors which can be the cause in pituitary, like a history of any persistent headaches or loss of smell. So that was covered very well. Then followed by breast and uterus and ovaries. So the level wise it was covered. You were very systematic, so that I liked. And then coming to the examination part also. So examination also in a serial systematic manner it was covered, starting from the general physical examination and followed by the targeted respiratory, cardiovascular, and then the abdominal examination, so which was covered very well. And then we had the investigations. So the diagnosis was correctly made that it is MRKH, because the karyotype is 46XX, and there is absent uterus, and there is upper third of vagina is absent. If it was for 46XY, then it would have been a Swire syndrome. So the diagnosis was correct. And then followed by that, the management plan. So how it was managed sensitively, involving the multidisciplinary team and referring her to the psychological support after hearing this news. So that was conveyed very well. And the options of non-surgical and surgical management also, including according to each part, like the sexual function, the fertility part was covered very well. So I think it was overall good, Dr. Sowmya.
Thank you. Thank you, Priya. Just let me take them through what is more, what probably I had missed. See, guys, I always believe in giving an examiner a good chance to mark you better. So even if you miss few things, like the definitions, of course, you are supposed to be knowing. It's always a good idea to talk about the hypothalamus, pituitary, breast, thyroid. So you will not be missing on any of those things. Of course, it's very easy, even in periods of stress, and uterus and ovaries as well. Physical examination, the one word Tana stating, if you speak about, they would understand what you mean, because those things are very important. If you notice, I actually didn't mention about the visual field testing and signs of hypopituitarism, because it was becoming too much for me to explain so many things. But yes, in the exam, it's always a good idea if you could explain the way I went, like hypothalamus, pituitary, breast, uterus, ovaries. In that only, if you actually go through, you will not be missing even those 1 or 2 points. And investigations, never ever forget the pregnancy test, because if you forget, you will be marked down. And ultrasounds, see, hormonal test you could do. There is a progesterone withdrawal test, but it is not very authenticated. So that's why I haven't mentioned. It's always a good idea to speak about hormone test, ultrasound, and then go for the karyotyping. And MRI and renal ultrasound are not routinely performed. So mention when you would be doing. And of course, whenever they give the investigations here, I have made it easy by giving the interpretation. So you have a reference range also. And when you get the karyotyping, always see whether there is any Y chromosome, which is not here. It's 46XX. And also, if you could see, uterus is absent. So that means to say we are dealing with MRKH and MDT, and you have to divide into the topics. If you don't know this Vichetti, Dado procedure, McIndoes, don't worry. Just mention you need to create a neovagina either by traction or by using a peritoneum mold or by using a sigmoid valve. Or if you don't even remember, you said that there are surgical procedures to create neovagina. That's fine, even if you haven't heard of. And of course, fertility and the uterine transplant is always a good idea to mention. So just to add on to what global criteria of pass, borderline, fail comes, and pass always talks about clearly identifying the first line, second line, and logical and systematic and comprehensive. That's very, very important. And make sure that if, even though it is a communication with colleagues or you're discussing with your consultant, mention about the empathetic and sympathetic part for the patient, because this is not an easy diagnosis. Fail is very crystal clear, where you don't diagnose, where you are disorganized, where you move from uterus to pituitary to hypothalamus, things like that. And obviously, inappropriate managements and poor communication, clear fail. And borderline, most of the students lay in borderline. If you miss beta HCG, you automatically come to borderline even with all that. So just remember that. Guys, these tasks are generally very easy peasy. So just make sure to follow a protocol and be systematic. Then definitely success would be yours. Hope this is useful. Don't forget to drop a feedback so that we know we are running on the right track. Thank you, Priya, for your time. I know you're busy in the clinic. Thank you so much for joining. Thank you so much.
Thank you so much.